Hello everyone, my name is Anthony Gon and this time I will talk about immunotherapy in renal cell carcinoma. Definition: renal cell carcinoma is a type of kidney cancer that begins in the lining of the small tubes of the kidney. It is a highly metastatic. This type of cancer is more common in older men. Cholestoxin injection could lead to tumor shrinkage.
So in moving forward, clearly, almost for the last decade, we've successfully, as Danny pointed out, extended progression-free survival, more than doubled, sometimes tripled overall survival. It's been an absolutely dramatic time for most kidney cancer patients. But having said that, where we have fallen short is that chronic therapy is required. Coming off therapy, disease progresses. Oral agents are still associated with significant, potentially life-changing side effects that change how people do, and we need to be looking for new approaches. And at this past ASCO and throughout our literature, it's very clear that we're revisiting, Jan, the role of immune-based therapy. For those of us that have given immune-based therapy for years, one recognizes that in our practices, if you ask the question, what's the most likely therapy a person received for a period of time and then had an unmaintained remission for years or decades, it's IL-2. And yes, IL-2 is difficult to give, and yes, IL-2 doesn't work in most people, but it does tell us something about biology. So the question, Jan, is are we revisiting the role of immune therapy in kidney cancer, and if so, how? And are we doing it the right way? Did we learn the right lessons from the first experience? Are we applying it in the second experience? And are the endpoints, the biomarkers that we're looking for in the patient populations, the right populations? That's a lot on your plate, but take a stab at it.
Thank you. Yes, immunotherapy is having a resurgence of interest, no question about it. Yesterday morning, we actually had a Society of Immunotherapy of Cancer symposium to talk about different approaches. And I will talk to your specific question, which is about the new understanding of taking the brake off the immune system with checkpoint inhibitors. But I wanted to just mention one point that was made, which is still underexplored and needs further evaluation, which is the combination of stereotactic radiation with immunotherapy to get an abscopal effect on tumor. And that has not been well explored in humans, but very well documented in animals. So that's another direction that immunotherapy is going.
Application in medicine. Immunotherapy is the use of drugs to boost a person's immune system so that it recognizes and kills cancer cells more effectively.
I think that kidney cancer is a fascinating disease, and I think that there's been an explosion of information about kidney cancer. I think that was one of the first tumors by looking at the patients with von Hippel-Lindau's disease, which is an inherited form of kidney cancer, to begin to understand the genetics and the genomic factors in kidney cancer. And that's led to the tyrosine kinase inhibitors, the mTOR inhibitors, and now, while we historically believed that kidney cancer was a tumor that can be treated by the immune system, with the checkpoint inhibitors, we see now a new, renewed interest in treating kidney cancer using immune therapies. And I think that again, cancer is a very heterogeneous and diverse disease. Just like there's heterogeneity and diversity in normal people, there is a lot of heterogeneity and diversity in cancer. And so no one approach, it's not going to be a one-size-fits-all. The goal in the future of cancer therapy is to identify biomarkers which help us predict which treatments to use, potentially even which combinations of treatments and which sequence of treatments. So it's complicated. I think that the President Obama is talking about precision medicine and putting more money into precision medicine, and absolutely, but it's not going to be so simple. There's a real significant complexity, but I think that we're much further along than we were. And again, you can't emphasize enough the importance of basic science research. One of the things that we keep coming back to with cancer is we need to understand the biology of cancer better. And as we understand the biology of cancer better, we're able to identify therapeutic targets to treat. And then ultimately, in our country, let's try to prevent cancer. And that's something that, again, by understanding the biology of the disease, potentially we can identify the triggers that turn on cancers and how to potentially alter those triggers.
Pros and cons. Pros: rapid response, direct defense, pattern recognition. There is a wide range of therapies for kidney cancer. Cons: slow adaptive response, clonal expansion. It cannot be effective all the times or if the cancer is advanced.
So the next wave is these checkpoint inhibitors. There's at least 4 or 5 trials that I know of. I think only one with atezolizumab that's actually up and running. Others with nivolumab and durvalumab, and also, I mean, any drug you can imagine will be tested in that setting. It probably makes a lot more sense. It's going to be better tolerated for patients, I think. I think probably has the potential to extend overall survival, which would be ideal, which we haven't done to date, even with S-TRAC. And so we'll have those results in many years, but I think probably if we're sitting here in 5 to 10 years, we'll be talking about those drugs as standard of care.
Insight applied in Ecuador. Renal cell carcinoma is a third urological cancer, representing 3% of all cancer in women and 5% in men, with an incidence of around 400,000 cases worldwide.
I think the most interesting data and the one that people are very excited about is the Emotion 151 that we just heard from Dr. Bob Moser. And this is a phase 3 randomized trial that looks at bevacizumab with atezolizumab versus sunitinib in a phase 3 setting for advanced metastatic clear cell kidney cancer. So let me just give you a little background on how we treat kidney cancers or advanced kidney cancers. So certainly there has been a lot of landscape changes. In the past, if we go back even a decade ago, we really did not have a lot of systemic therapies to offer. But now we have VEGF inhibitors. So these are what we call the TKIs. And certainly we have the immunotherapy drugs, but mostly for second line right now. So with the advent of these trial, the landscape of treatment is really changing. So in this phase 3 trial, though, what they saw was a phenomenal and very compelling improvement in the progression-free survival. The overall survival is yet immature, but we are seeing that there is 2 co-primary endpoints. One is progression-free survival in patients who are PD-L1 positive, and in this population, there was about 40% of them, as well as an intent-to-treat population. And what they found was the PFS, for instance, for the combined therapy is in the order of 11.2 months, compared to only about 7 months for the sunitinib arm. So these are compelling data. And in terms of toxicity, actually there's not a whole lot that it's unexpected, if you will. So I think it's a fairly tolerable regimen. So I think moving forward, this is a great candidate. Perhaps, we will be seeing more this year. I think it's rapidly evolving. And the trial I just mentioned, the emotion trial, is but one of them. Last year at ESMO, we heard about the Checkmate 214 trial, which looked at the combination of nivolumab and ipilimumab versus, again, sunitinib, and that was also a positive trial. So we are starting to see now these combination IO drugs that are pretty soon going to be changing the landscape of treatment, because right now IO therapy has largely been second line therapy with nivolumab. So I think we are starting to see these agents move up, and not just maybe single agents, but in combination.
Conclusion. Novel combination strategies are being explored to deepen and extend response achieved with immune checkpoint inhibitor-based therapy.
So the things are clearly evolving for several years now, but especially since last ESMO, where we had the results of nivolumab versus everolimus randomized phase 3 study, which demonstrated that in patients who fail one or two VEGF-targeted therapy, there is a role for IO, immuno-oncology, and namely nivolumab. It is important because this is changing one of our standard of care, and since last year, this has been implemented in all the guidelines. What is important at this ESMO is that we're starting to have more information on which will be the next step in terms of combining those agents, for instance.
Thank you.